All right, welcome everyone. If you're gearing up for the OCS or just trying to get a better handle on that tricky posterior and lateral hip pain, then you are in exactly the right place. Today, we're going to build a really solid, evidence-based framework for clinical reasoning that's designed to hold up when you're under pressure in the clinic. Okay, let's get into it. Oh man, we have all seen this patient walk through our door, right? The story is so classic. But the actual source of the pain, well, that could be anything from an S1 radiculopathy to a hamstring issue or maybe a deep gluteal syndrome. You know, the posterior hip is just an anatomically crowded neighborhood, and our job is to be expert detectives. So this case right here, this is our puzzle for the day. And I promise, by the end of this, you are going to have the tools to solve it with confidence. So here's our game plan for this diagnostic deep dive. First, we're going to get really good at telling the difference between the key players here. Then we'll zero in on picking the right tests, the ones with the best stats to back them up. After that, we'll get into the rehab for conditions inside the joint, and we're going to take a hard look at a really common recommendation, NSAIDs. By the time we're done, you'll be able to pull this entire framework together to crack a tough case. This is your blueprint. All right, first things first, we have to master the conditions that live outside the joint capsule. You know, these extra-articular syndromes are super common, they love to mimic each other, and they can easily trick you into thinking it's a back or SI joint problem. So we're going to break them down, piece by piece, starting with the #1 cause of lateral hip pain. For years, we all called this trochanteric bursitis, but we know better now. Greater trochanteric pain syndrome, or GTPS, is really an umbrella term. It acknowledges that the pain is usually coming from a breakdown of the gluteus medius and minimus tendons. The bursa getting irritated, that's usually just a side effect. And this is a huge shift in thinking, right? We're moving away from just treating inflammation and toward treating an actual tendinopathy. So what does this patient look like when they show up in your clinic? Well, the pattern is pretty classic. They'll tell you about that hallmark pain on the side of the hip, they can't sleep on that side at night, and it just gets angrier with things like standing for too long or climbing stairs. Objectively, your hands are going to be your best tool. You should find some serious tenderness when you palpate right over those gluteal tendon insertions. And you'll be able to reproduce their pain with some really useful tests, like the single leg stance test. Having them stand on one leg for 30 seconds has actually been shown to have a high sensitivity for GTPS. Okay, now this is where it gets really interesting, because this is the why. At its core, GTPS is a movement problem. It's caused by the hip repeatedly falling into too much adduction and internal rotation during weight-bearing activities. Just picture that classic hip drop you see when someone's running. That movement pattern creates this nasty combination of stretching and compression right on those gluteal tendons as they wrap around the bone. This is the mechanism we have to fix in rehab. Okay, let's move a little more toward the midline, deep into the gluteal region, and talk about piriformis syndrome. The definition here is so key. It's buttock pain, but the absolute game changer is that potential for sciatic nerve entrapment. See, the sciatic nerve and the piriformis muscle are best friends, anatomically speaking. The nerve usually passes right underneath the muscle. So when that muscle gets overworked or tight or spasmed, it can literally squeeze the nerve. And boom, you get that sciatica-like picture. Now, figuring this out can be tricky, but a systematic review from Ho-Pai Yen and Daniel Yen gives us a fantastic clinical checklist. And while we have to admit the overall evidence quality isn't super high, they pulled out the 4 most common findings. First, buttock pain. Second, and this is a big one, pain that gets way worse with sitting for more than 15 or 20 minutes, you know, the classic wallet sign. Third, you'll find tenderness when you palpate near the greater sciatic notch. And finally, you can reproduce their pain with tests that either stretch or contract that piriformis muscle. So this is the million-dollar question. You absolutely have to be able to tell the difference between piriformis syndrome and a true lumbar radiculopathy. So how do we do it? You look for the patterns. Piriformis pain is almost always worse with sitting because you're compressing the muscle. Lumbar disc pain, often worse with standing and walking from the axial load. With piriformis syndrome, you'll find that deep, specific tenderness right in the buttock. With a radiculopathy, you might find tenderness over the spine itself. And finally, your objective screen is everything. A piriformis diagnosis is really only made with a negative lumbar screen and positive piriformis-specific tests. Okay, let's talk about a diagnosis that's less common, but you've got to have it on your radar. Ischiofemoral impingement, or IFI. This is all about a dynamic compression problem. It's not the hip joint itself, it's the space between the lesser trochanter of the femur and the ischial tuberosity, your sit bone. And what lives in that space? The quadratus femoris muscle. When that space narrows during movement, that poor muscle just gets pinched. And this number right here, this perfectly illustrates the problem. On imaging, like an MRI, a diagnosis of IFII is supported when that ischiofemoral space measures less than 20 millimeters. Now, obviously we don't have X-ray vision in the clinic, but just knowing this anatomical fact helps us understand the mechanism we're dealing with. Our job is to find the clinical signs that point to this narrowing. So how do we even start to suspect IFI in the clinic? Well, the single biggest clue is deep gluteal pain that is specifically brought on by end-range hip extension. So think about the very end of your gait cycle, or the trailing leg in a lunge, or kicking a ball. That's when that space is at its smallest. You can test this by having them do a long stride walking test, and you should also try to palpate deep to the glutes for that quadratus femoris. But remember, IFI is pretty rare, so it's usually a diagnosis of exclusion. You get there after you've ruled out all the more common culprits. Okay, great job. We've covered the key players outside the joint. Now, let's shift gears and move our focus inside the joint capsule. We're going to build a treatment blueprint for some common intra-articular conditions, and we'll focus on the evidence that should really be guiding our hands. But before we jump into specific rehab protocols, let's tackle a really common question about medication. Our patients are often popping non-steroidal anti-inflammatory drugs, NSAIDs, to manage their pain and keep going. But for our active people, our athletes, is this really a good idea? The evidence is starting to suggest that we need to be really, really careful. So, a study by Hughes and colleagues looked at the U.S. Army population and found something pretty shocking. They found that using NSAIDs was associated with a 2.9 times greater risk for stress fractures. Now think about it. This is in a young, active, load-bearing population, which sounds a lot like the patients we see in our clinics, right? It raises some serious questions about what these drugs are doing to bone health under stress. And if you thought 2.9 was high, check this out. During periods of a major spike in activity, like basic combat training, that risk jumped to 5.3 times. This strongly suggests there's a dose-response thing happening here between activity level and risk. The take-home message is huge. For our athletes, NSAIDs are not a free pass. They might be masking the very pain that's signaling bone stress, while at the same time potentially messing with the bone's ability to heal and adapt. It's a perfect storm for a bad injury. Okay, so let's build our rehab plan for femoroacetabular impingement syndrome, or FAIS. It's really a multi-step approach. Step 1 is always education and activity modification. You have to teach patients to stay out of those positions that cause the impingement, that deep flexion and internal rotation. Step 2, we can absolutely use our manual therapy skills to help with pain and improve their movement. Step 3 is the real meat and potatoes, neuromuscular control. We've got to fix that valgus collapse and build up the strength of the hip abductors and rotators. And finally, for our athletes, we need a really solid return to sport testing plan. Now, listen to this quote from Jacobs and colleagues because it's a real paradigm shifter. We can get so hyper-focused on the shape of the bones and the labral tear that we see on an MRI report. But this research found that a patient's symptoms, their actual pain and what they can't do, had a stronger link to their mental health scores than to how bad the structural damage actually was. This is a huge reminder that we have to treat the whole person, not just the hip. We cannot afford to ignore the psychosocial factors that are at play. Now, this is absolutely critical. You have to know the difference between our strategy for FAIS and our strategy for hip microinstability because they are polar opposites. For FAIS, the goal is to create space and reduce compression so we avoid end-range flexion and internal rotation. For microinstability, the goal is to improve stability and control excess movement. So here, we have to avoid the things that stress the front of the capsule. That's end-range extension and external rotation. If you apply the wrong principle to the wrong patient, you can make them so much worse. Okay, we have covered a ton of diagnostic and treatment ground. So now it is time to put it all together. Let's go back to that runner we met at the very beginning, and let's see if you can solve the case. It's your turn to make the call. So here's the subjective again. 45-year-old runner. Deep, nagging pain in the right buttock. The big red flag? Sitting for more than 20 minutes is just awful. And they're getting some weird sensation down the leg, but, and this is a key clue, it doesn't go past the knee. Just listen to those clues. What hypotheses are starting to bubble up in your mind right now? All right, here is your first big decision. Based on that history alone, what are your top 2 differential diagnoses? And, maybe more importantly, what are the first two objective tests you're going to do to either prove or disprove those ideas? Go ahead and pause here and really commit to an answer. Okay, you ready? If you said piriformis syndrome because of that deep buttock pain and how much sitting makes it worse, you are definitely on the right track. And you have to have lumbar radiculopathy on your list because of those radiating symptoms. So, what do you do next? Your next two tests should be a seated piriformis test to see if you can provoke it locally, and a full lumbar screen, including a slump test or an SLR to rule the spine in or out. Excellent work on that case, seriously. Now, to make sure all this information really gets locked in for your exams and for your clinic, we're going to do a quick round of rapid-fire retrieval practice. I'll ask the question, you pull the answer from your memory. Ready? Let's do it. All right, let's check your work. What's the primary pathomechanical driver for GTPS? That's right, excessive hip adduction and internal rotation. What's the critical measurement for the ischiofemoral space in IFI? Less than 20 millimeters. What was that crazy risk multiplier for stress fractures with NSAIDs use during basic training? A staggering 5.3 times. And finally, what's the key joint protection strategy for microinstability? Avoid forceful end range extension and external rotation. How'd you do? If you nailed all four, you are in fantastic shape. Woo! We have covered a massive amount of information. So, to wrap it all up, I want to boil this all down to the 5 most important board-relevant points that you absolutely need to walk away with today. Okay, so if you only remember 5 things, make it these. Number 1, differentiate systematically. Always clear the spine first. Number 2, test with purpose. Use tests that the evidence actually supports. Number 3, scrutinize NSAID use. You have to educate your active patients on the risks. Number 4, treat the person with phys, not just the x-ray. Address the psychosocial stuff. And number 5, with instability, you always protect the joint before you strengthen around it. These 5 principles right here, they're the core of your clinical framework. And I'll leave you with one last question to think about. Knowing what we now know from that Jacob study, that powerful link between mental health and FAIS symptoms, how can you evolve your own clinical practice? How might you change your initial patient interview to better and more compassionately screen for these psychosocial factors that could be the real driver behind your patient's pain? Something to chew on. Thanks so much for joining me for this deep dive.